Amazing. If anybody else is like me and you've done either a Zumba or an Aquafit or something to Uptown Funk, I know you were just moving in your seats as well. So, welcome back, everybody. Thank you for joining us for the rest of today. Hopefully, you're enjoying the program so far. I think we've done a fantastic job of including patient perspective. We've talked about mental health. We've talked about surgical options. We've talked about nutritional therapy. And now we're going to move into a conversation that really addresses that pharmacotherapy side of things and medications. So we'll be heading into obesity medications, how they support healthy living. And it is my pleasure to welcome to the stage Dr. Priya Manjoo. Priya is a specialist in internal medicine and endocrinology. She's a diplomat of the American Board of Obesity Medicine, which is a huge thing. Being an ABOM certified, we don't have many in Canada. We're lucky to have Priya, as well as a certified hypertension specialist. She's the co-director of the Victoria Cardiometabolic, Collaborative Clinic, the chair of the Science Committee and the clinical committees of Obesity Canada. She was a co-author of the clinical practice guidelines that are really informing our part today. And I get the joy of spending time with her in board meetings, and she takes the board right out of board meetings. I can tell you that as well. So welcome, Priya. Thank you for joining us today. We are super excited to hear everything that you have to share today.
Thank you for that lovely introduction. That's a lot to live up to.
No pressure.
I'm very honored to be a part of this program today. And, I have a lot of respect for everything that Obesity Canada has done. And I'm very, again, honored to be a part of this. So I will be talking about pharmacotherapy today, and I'd like to just jump right in. Okay, so my talk today is on pharmacotherapy in the context of overall management of obesity. Can you move to the next slide, please? So I will start by talking about some of the limitations of how we measure adiposity and weight. And then with that understanding, we'll discuss the prevalence and public health impact. I want to focus on the patient experience and how that is affected by the neurobiology underlying obesity, and then talk about how our approach to weight management has changed because of better understanding of that patient experience and new understandings of obesity neurobiology. And then with that context, we'll talk about pharmacotherapy. So I'll go to my first slide, which, these are my disclosures. And then the next slide. So measuring adiposity is very important. In some ways, it has restricted how we treat patients. The next slide shows how we are supposed to define obesity. Obesity is defined as a chronic disease characterized by the presence of excessive or dysfunctional adipose tissue that impairs health and well-being. This next slide shows how we define BMI. And part of the problems with BMI is it's only a definition of size. It's your height and weight is used to determine your BMI. And it's a measure of size, but it's not really a measure of health. And the next slide shows data from the NHANES study. This wasn't great quality data. All this data showed was that if your weight was higher, your chances of dying were higher and your survival was lower. Next slide. But this BMI, as I mentioned before, doesn't really tell you how your health is affected. In fact, a group in Edmonton, a little over a decade ago, decided to look at weight in a different way and instead of just incorporating the size, also look at the comorbidities. And this was called the Edmonton Obesity Scoring System. And this next slide shows how the Edmonton Obesity Scoring System is applied. Stage 0 are patients who have no comorbidities, who have a higher weight but no functional impairment, no metabolic complications, no mechanical complications. In stage 1, there is a slight increase in risk factors. In stage 3, there are more risk factors. Stage 4 and 5, and then, in stage 5, obesity is more it's more strongly associated with functional impairment, damage to the end organs, and so this is how they defined obesity. And we'll go to the next slide. And then they took this system and they applied it to the initial data that was used to show that BMI was associated with decreased survival. And what you see in the top, and I'm not sure if I can I'm not sure, okay, there. Can everyone see my cursor? Hopefully. In this top left graphic, it shows what happens to these survival curves when you increase comorbidities. So you don't see my cursor, but the graphic to the top right shows that the curves are very similar until you start looking at the comorbidities associated with a particular weight. And that's when you start seeing that there's a difference based on those comorbidities in survival. So we'll go to the next slide. And even in the midst of the COVID-19 pandemic, there was data showing that BMI was associated with an increased risk of poor outcomes. But when we used the Edmonton Obesity Scale, we found that it was mostly the comorbidities associated with obesity that was driving the poor outcomes, and not specifically the BMI itself. Can we go to the next slide? So based on this, we'll go to the next slide. Thank you. So based on this, we've recognized that there are a lot of limitations of BMI. There's a lot of cultural heterogeneity in what's considered to be normal and accepted in terms of body size, and that can create barriers to discussions about healthcare. BMI is a very crude predictor of the type of weight that you have. It doesn't differentiate between muscle or healthy fat or unhealthy fat. There's a difference between your BMI and your health, and changes in your BMI do not always reflect changes in your health. Unfortunately, we are somewhat bound by BMI because many of the measures of how the prevalence of obesity in our society is based on BMI, and a lot of the clinical trials are based on BMI. So it really does limit access to care in some patients who have adiposity-related diseases, but at lower BMIs, and access to bariatric surgery is still based on this fairly crude marker of weight and health. Go to the next slide. So again, I will say that when we talk about the epidemiology of obesity in Canada, it's based on BMI. And we know that there are very strong social and demographic factors like age and sex and ethnicity, indigenous and immigration status that affects obesity. We know that between 2001 and 2012, there was a similar increase using that BMI cutoff of 30 for men and women, but men have increased. There's more men with less severe. There are more men with lower class of BMI and more women achieving higher classes of BMI. Immigrants have a lower rate of obesity compared to people who've been living in Canada for longer. And so it is very important to consider environmental influences on weight. Let's go to the next slide. And then I thought that this was sort of interesting just to highlight to you some of the pitfalls of BMI. And I promise you this is the last slide I'll talk about BMI. But when you look at ethnicity and the influence on obesity and obesity-related complications, within Ontario, there are similar rates of obesity in white and in persons of white and black ethnicity, but much lower rates in South Asian and Chinese populations. But when you start using a lower BMI cutoff for those populations of South Asian and Chinese patients, then the rate of BMI sort of equalizes. We know that the rates of obesity in patients of Aboriginal descent are actually even higher than within Caucasian and Black ethnicities. So we'll go to the next slide. And so now we'll talk a bit about the neurobiology of obesity. This next slide shows the patient experience. And I think for each patient, it is important that the healthcare practitioner and the team understands their specific patient experience. Each patient's experience is like a thumbprint, it's like a fingerprint, and it gives insight both to the healthcare practitioners and to the patient on the specific causes of obesity and increase or changes in weight. We'll go to the next slide. And you can see that for everyone, it's different. For some people, it's children. For some people, it's moving countries, the first job, the relocation. And so it really is worthwhile understanding this. Next slide. We know that obesity and mental health are very strongly associated. And the presence of obesity can make it harder to treat mental health issues. And the presence of mental health issues can predispose patients to adiposity-related diseases. And so it's very important to look at this aspect when you're considering pharmacotherapy and treatment. Go to the next slide. Great. So before we consider pharmacotherapy, we have to understand that an intervention is not a cure. When you intervene to affect someone's engagement in healthy behaviors and their weight, whether it be surgery, medical nutrition therapy, exercise, or pharmacotherapy, the treatment works as long as one is taking it and compliant with it. But when the treatment stops, the weight returns. And so that space between the rebound weight and the maintenance of the weight loss is that therapeutic space that we're trying to optimize with medication and some of the other pharmacotherapeutic options. Next slide. When we start treating patients, it doesn't matter what weight you start at. The percentage weight loss the percentage weight loss tends to be about 5 to 15%. For some people, it's less. For some people, it's more. But the earlier you intervene, the lower the weight is that you're likely to achieve. And that pulls the patient away from that risk. And that's where that weight is. The more weight loss you are able to achieve, the lower your risk. Now, that doesn't mean that you can achieve you can achieve greater health with lower weight. You always have to sort of look at how that weight correlates with health. So we'll go to the next slide. And so the next couple of slides after this will try to explain the weight loss and weight gain and the neurobiology that underlies this process, because that's really important in understanding what we're trying to achieve with pharmacotherapy. Can we go to the next slide? Okay, so the next slide shows what we understand about the regulation of appetite. I am not going to go through this slide, and I promise you it is a gross simplification of what appetite control and behavior control is really about from a neurobiological basis. But the next slide tries to sort of simplify the concepts that we understand. There are 3 drivers of appetite that we are understanding. There are probably more, and this is, again, a simplification. But there is that part of the brain that is hardwired into each of us. And that is the part of the brain that functions to ensure that we achieve and maintain the highest weight we can in times of starvation, because that is the definition of success. That is the homeostatic pathway that tries to protect us against weight loss. It doesn't do as good a job of protecting us against weight gain. So that pathway, though, is supposed to shut off when the signals to the brain tell us that we're getting enough nutrients and we have enough stores of fat in our bodies. Then there's the hedonic eating pathway. This is the pathway that stimulates appetite based on the pleasure of eating, the emotional comfort of eating. And this is something that gets programmed into us at very early ages. And there's the whole literature about this part of this sort of stimulus to appetite. And it is very pervasive in our brains. And it does not shut off when our bodies are telling us that we have enough. And then, so these two pathways, and we'll go to the next slide, these two pathways are both acting in unison to send signals to the top of the brain. A lot of these signals don't really reach consciousness, but if we go to the next slide, but based on these signals, our executive function, the part of our brain that makes decisions, has to decide, are we going to eat or are we not going to eat? And so the pharmacotherapy that we use, the behavioral interventions that we use, are meant to influence this process in favor of helping the patient to choose the healthy behaviors in times of stress, in times where the environment is telling them to eat. So this is, again, a simplification. We'll go to the next slide. Okay, but it's important to understand this when we talk about pharmacotherapy. So this is what we're supposed to do. This is what pharmacotherapy is supposed to do. It's supposed to tip this process or the outcomes in favor of health. So our approach to obesity management has changed, and it's changed based on the next slide. It's changed based on how our understanding of this process and the patient experience has changed. We've recognized now that obesity is a chronic disease. We understand the impact of bias and stigma and discrimination, both in patients' access to healthcare and in ways in which the healthcare system can support patients or not support them. We understand the neurobiology. We understand that patients can't control their weight. They can control their healthy behaviors or their engagement in behaviors, but you cannot will your weight down. We understand, with that in mind, we use new treatments and therapies to help improve patient outcomes. And it's very important that that approach is tailored to the specific patient. So we'll go to the next slide. I think this is a topic that we could talk about for hours. This is a very important topic. I'm not going to go into this slide, but I want to show it to you because it's very important for healthcare practitioners and it's very important for patients. We'll go to the next slide. Okay, so now we can start our talk about pharmacotherapy. But again, pharmacotherapy is more than just prescribing a drug for weight loss. It's about understanding what we're trying to achieve with this drug and understanding the limitations of how we measure outcomes. Can we go to the next slide? Okay, so there was a pharmacotherapy chapter in the obesity guidelines in 2020, which talked about 3 drugs. And in the update that was released last year, there have been recommendations about the 4th drug, semaglutide. And we've also talked about new patient populations that have been shown to benefit from pharmacotherapy. And so the next few slides will talk specifically about pharmacotherapy, determining the goals of therapy, choosing the right agent, measuring outcomes. And so I'll go to my next slide. Okay, so why do we use pharmacotherapy for obesity? We do this because in engagement in healthy behaviors does improve health. Further reductions in weight through those engagements can also assist in improving health. And in general, healthy behavior change alone achieves a 3 to 5% weight loss. And it's often not sustained over the long term because of that neurobiology, which ends up driving the weight back up as we lose weight. So obesity pharmacotherapy can facilitate weight management and optimize health when healthy eating and physical activity alone have been ineffective, insufficient, or without sustained benefit. Okay. Again, the focus should not be on the number on the scale, but it should be on the health outcomes, the improvements in metabolic health, the improvements in mechanical issues, the improvements in mental health, and very importantly, quality of life. There are many of my patients who say to me, the number on the scale hasn't shifted too much, but pharmacotherapy or the medications have made it a little bit easier for me to take control over what I eat and what I do, and it's easier for me. And so, that's a very important patient outcome. So again, titrating your therapy to the patient is extremely important. Let's go to the next slide. Okay, so this is an overview of weight management and the approach to weight management, and it shows you where in this comprehensive approach pharmacotherapy fits in. Medical nutrition therapy and physical activity have been discussed. Those are the things that the patient can do. Psychological interventions help to maintain that engagement. Pharmacotherapy can put the brakes on the neurobiology, making it easier for the patient to stay engaged. And it also allows your engagement in healthy behaviors to go further. Bariatric surgery has been a point of frustration for many of my patients because there is not as much access. So, I think that when we sort of look at this, we again see that pharmacotherapy is one pillar. Okay, can we go to the next slide? Okay, so the concepts of treatment, the important things, you want to treat. We showed slides that showed treating earlier can have better outcomes in the long run. Treating long term is also important because obesity is a chronic disease. Next slide. So getting down to the nitty-gritties of what agents we have, can we go to the next slide? Okay. Indications and medications approved. So we talked about the indications. Unfortunately, those indications for therapy, because of the way that the trials were structured, are still based on BMI criteria. But they are reasonable enough to permit treatment of patients who are overweight and not yet meeting the BMI criteria for obesity. There are 4 drugs that are approved in Canada. Orlistat is a pill that works by blocking the absorption of calories. Liraglutide is a drug that is an injectable agent once a day that works on the signaling in the gut and the brain to affect appetite. Naltrexone bupropion has a largely central effect to affect appetite and more emotional aspects of eating. Semaglutide, like liraglutide, is an injectable agent. It works on the gut and the brain to change signals of satiety. And really, we understand some of the ways in which these drugs work, but not everyone responds in the way that we expect. So let's go to the next slide. Okay, so before starting pharmacotherapy, one has to have an agreement with your patient, and patients have to agree on a plan with their physicians, identifying what are the goals of therapy. No drug is going to work and cause continuous weight loss. The drug will put the brakes on neurobiology to a certain extent, And then when you've lost weight, that neurobiology becomes more and more robust and starts screaming because the weight has gone down. And then it will be strong enough at one point to resist the effect of medications so weight stabilizes. Some of my patients say to me after 6 months, the medication has stopped working. And that's not necessarily true. It could just be that the medications have produced weight loss, activated a more robust neurobiological response that prevents further weight loss. So, identifying goals, those reasonable expectations should be around what a medication can realistically do, what comorbidities we want to see improvement in, and what targets of therapy are important for the patients. Some patients say that for them, they would like to be able to play with their grandchildren, or they want to have more energy, or they don't want to develop diabetes. And so titrating therapy to achieve those goals first are important. And then one can reassess the new state of health and determine what else needs to be done. So targets for treatment can be weight loss, improvement in health parameters. It can be for maintenance after periods of weight loss because persons are finding it harder to maintain that weight loss. And very importantly, quality of life. So the other very important consideration is to understand that pharmacotherapy is part of a long-term treatment. Let's go to the next slide. Okay, so we talked about the fact that treatment response is heterogeneous. Not everyone responds in the same way to a medication. Next slide, please. Okay, and so when we're choosing a specific pharmacotherapy, having identified goals, and we need to consider patient preferences and their values, their comorbidities, the mechanism of action, the side effects and tolerability, the safety given other comorbidities, the other medications that they are on so that there is no interaction. Frequency and mode of administration are very important. There are some patients who are shift workers who are not able to take pills twice a day, and those are barriers to compliance. Cost is probably the single most important determinant of a medication that a patient will choose. Can we go to the next slide? Okay, so cost and access. This diagram shows the different medications that are available and the cost, with the most expensive, the second most expensive, the least expensive, and then, of course, semaglutide, which is the new medication, we don't have costing for the weight loss doses yet. Next slide. Okay, and each medication has effects on different comorbidities, and that will be a determinant of what's chosen. So some of the outcomes, the effect on quality of life, on physical functioning, obstructive sleep apnea, various different things are different from each medication. And that should be a very important factor in determining what medication is chosen. And we'll go to the next slide. Okay, so the next few slides are about the specific recommendations based on our guideline update for these medications. And so I'm not going to go through them all in detail. I'm going to show it to you, but I'm going to go through just in a nutshell what each of them is about. So we'll go through these quite quickly. Next slide. Okay, so pharmacotherapy is recommended for obesity medication. Again, it's supposed to be used in conjunction with all the other treatments that we discussed. Next slide. We use pharmacotherapy not just for weight loss, but for maintenance of weight after a period of weight loss. And these guidelines are the first to recommend pharmacotherapy be used in that way. And that's because we recognize the importance of the neurobiological response to weight loss that makes it harder to persist with those healthy behaviors and maintain our weight. And that's what causes the yo-yoing that we want to avoid. Next slide. Pharmacotherapy can be used in people who have prediabetes to delay or prevent the onset of type 2 diabetes. Next slide. It has also been shown to improve outcomes in patients with type 2 diabetes because a big part of controlling glycemia in type 2 diabetes has to do with what we eat and how we engage in healthy behaviors. So it really is one of the important aspects of treating that particular comorbidity. Next slide. Okay, we have studies that show pharmacotherapy can improve outcomes specific to obstructive sleep apnea. Next slide. And parameters of fatty liver disease. Fatty liver disease is a new comorbidity that we are understanding. Rather, it's a comorbidity that has been there, but we have a new understanding of how it impacts glycemia and cardiovascular health. And so there's a lot of interest in trying to understand how the drugs that we have available can affect and improve parameters of fatty liver. Next slide. Okay. We talked a little bit before about mental health. There's a lot of overlap between the treatment of mental health and obesity treatment because the two conditions tend to affect each other negatively. In treating patients with mental health issues, it's important to be aware of the weight gain that occurs with certain antipsychotic medications. And metformin, it's not a weight loss medication, but it can prevent weight gain in persons who need to be treated. Next slide. Okay. And so we also recommend care in choosing not just pharmacotherapy for obesity management, but any pharmacotherapy for patients who have obesity. We should be choosing or we should be considering drugs that limit weight gain. So choose the drugs that are weight neutral if you're treating diabetes or hypertension, etc. Next slide. And we do not suggest the use of prescription or over-the-counter medications. And that is because to treat obesity. And that's because every single drug comes with side effects. And understanding how a drug can affect a patient's goals of treatment are very important. We don't have that information for drugs other than the 4 drugs that we discussed. Next slide. Okay, so the next slide is the decision tool. This is what we've sort of, next slide. Okay, so when you're choosing pharmacotherapy, we discussed the agreement on therapy, then information is given to all patients on the available therapies, and the next step is determined by access. If there's no access to medications, there are ongoing advocacy initiatives to improve access to patients. I try to encourage patients to write to their MLA to let them know that this is a problem that's affecting them. And I think if there's a louder voice from everyone, then it's a voice that's less likely to be ignored. If there's limited or access or full access to medications, then we look at the goals of therapy, the contraindications, and the patient values and preferences. Then medication is started, and those goals of therapy are reassessed in 3 to 6 months. If the goals are not met, we have to think about why are they not met, and then consider adding or substituting another medication. If they are met, if those goals are met, we continue medication and then reassess. Everyone's health status changes, everyone's environments change, and so that's very important to do that reassessment. Next slide. Okay, and I think I showed you this again. This last column shows the provincial coverage for obesity pharmacotherapy. I really hope that in the next year or two that this changes and we can see an improvement in that, and hopefully we have some coverage. Next slide. And the next slide. Okay, so I'm just gonna just wrap up. This is my last couple of slides here. Next slide that shows just pharmacotherapy, our key messages. They're effective, they're scalable, meaning that if they work and we have access to them, they can be applied to more people than, say, bariatric surgery, for example. Pharmacotherapy is one in a number of pillars and part of a comprehensive plan for obesity management. And the focus should be not on the weight or the number on the scale, but rather the improvement in health. And it should include the outcomes that the patient identifies as important. And it's part of a long-term strategy. Next slide. Okay, so that is the end of my presentation, but I encourage everyone to visit the clinical practice guidelines online, and we'll go to the next slide. And that's it. The next slide should have been questions, but there we go. Perfect.
Fantastic. Well, we do have some questions coming in as well, Priya, but
Great.
I wanted to just
Perfect.
pump my brakes, my neurobiological brakes for a moment and say thank you. I think that was super helpful and really informative. And as someone who has navigated a few of these medications, I have to say I took some notes and learned some things
Great.
myself. I also really, really appreciate you giving a shout out to writing your MLAs. And I'm going to just get on my soapbox for 1 second and echo that sentiment because it is a conversation and reflected in the questions we're going to head to as well.
Yeah.
But, it's really important for each of us to understand this is how the world works. We need to be squeaky wheels. And our MLAs are there to serve us. Our government is here to serve us. Our dollars matter. Our votes matter. We need to be louder, and we can be
Yes.
louder together. And I know Ian and I are very committed to making that as easy as possible as well with really easy turnkey letter writing campaigns, those
Oh,
kinds of
good.
things. So
Perfect. I
yeah.
did write,
So
I will mention that I did write an article recently. I'm not sure if it's published yet, but just highlighting the fact that we cover medications that treat obesity related complications. And we know
mm,
that adequate weight loss can reverse those complications. So it's a very unusual approach, and that was reasonable years ago when we didn't have effective obesity treatments, but now we do. So it's time to look at that algorithm, and you look at the Diabetes Canada, the ADA, hypertension Canada, and a lot of these places now have lifestyle interventions, behavior change, weight management at the top of the algorithm. So it's
mhm.
now time to take that science and show it and showcase it and try and get things turned around.
Totally, because we're kind of wagging the dog right now. We've got it
We,
a little backwards, right? But let's move to the question. And I don't know if you were listening earlier today when we got a little spicy talking about the Ozempic and semaglutide conversations that are in the news. So it's definitely been getting a lot of attention. It's exciting. But where do you think we're going with medications for obesity? And do you know if there's any other medications coming? I know Ozempic seems to be getting a lot of noise right now, and that's really
yeah,
Wegovy coming forward.
yeah. I'm
Thoughts?
always a little bit cautious about using Ozempic for weight loss. Ozempic is a diabetes medication. We are using it off label for weight loss, and that can make it a little bit harder when Wegovy comes along to get that third party coverage. So, I think it's just something to consider. In terms of the pipeline, there are many things. We have shown an extensive neurobiology. There are molecules on the horizon that a single molecule can affect not just GLP, but GIP and glucagon, and drugs that can affect other aspects of that pathway. Cagrilintide, for example, is another one. Amylin agonists. So these are just it's huge. But until those drugs are tested in clinical trials, we're not going to have the safety data and know whether or not it can be helpful to patients, because this is long-term therapy, and that's why it's
Mm.
important to have longer-term data.
Like, I'm gonna write that down for a second because that is
Yeah,
really true, isn't it? Like, yeah,
long-term.
I
Yeah, we've
I
had
hadn't
some
thought of that.
stumbles with weight loss pharmacotherapy in the past that have had us,
Hmm.
some of them have been taken off the market. The drugs that we have, like naltrexone, bupropion, liraglutide, semaglutide, they don't actually cause the weight loss as such, right?
Mm,
That's really important. They
yeah.
change, they affect
Mechanics?
behavior. Yeah, they influence behaviors. They change your eating behaviors by their effect on appetite and satiety and the emotional aspects of eating. But they're not actually causing the weight loss. We're not raising our energy expenditure. We're not fixing metabolism, right? So
Hmm.
that's important.
Ah,
They only work well if you're doing the other pillars as well.
yes, exactly. It's one of many. So another question that came through is the question is written as, my understanding is that Cadth
Hadith.
thank you, recommended not funding these meds because of lack of meaningful benefits to justify taxpayer dollars. Do you have any thoughts on that or any insights around that?
Um, as
And
far
you
as
may
I
not,
know,
which is fine.
yeah, no, that's interesting. I think you don't have third party coverage if KDIC hasn't recommended it. So there is third party coverage for Saxenda. There is third party coverage for Orlistat and naltrexone bupropion. So I don't think KDIC has made a recommendation against that. Now I'm not sure if that is referring to if that's referring to semaglutide or not. I would have to check into that. KDIC is
Mm-hmm.
not a static thing. So often if someone appeals, they can present new information, new advocacy tools, and it can get passed. So that may be the state now, but I'm hoping that that's not. It says here, KDIC did make a recommendation to not cover SEMA or LIRA for public coverage. Well, that's
Mm.
horrible. So I think that's something we have to fight against. Again, we're
Yeah.
covering medications. If you're looking at a cost-effective model, I've had patients who've been on one weight loss pharmacotherapy, and we've been able to discontinue a couple of drugs, which is great because compliance to fewer
Mm.
drugs is improved. The long term cost is improved. We're targeting benefits in three different realms where we're able to reduce medication. I would like to understand better why KDIC would make that recommendation. And I
Hmm.
would love to talk to KDIC if they wanted to talk to me.
Excellent.
I'd be happy to discuss that. I'm sure a lot of
We'll go find their front door, my
I
friend. It's going
I
to
think
happen.
a lot of persons who treat patients with obesity would be happy to advocate there and give an opinion if that would
There's
help.
just, yeah, I love the way you phrase that as well. It's kind of time for the update. We have the science now, and when we know better, we should be doing better.
Mhm.
And let's just let the science lead, because again, you can have your own opinions, but not your own facts.
Yeah.
And that is really where we need to root from. One last question before we wrap up. Now that medications have been on the market for some time, are there any side effects appearing that weren't evident in original studies from your
Mm.
experience?
Yeah. So I think any medication can cause any side effect in a given person. So I think that the more you use a drug, the more you're going to find side effects. There is, whether that side effect is related, whether the occurrence of a particular sign or symptom is related to that drug is is a little bit harder to determine. For example, I have patients who have fleeting muscle pains over 10 years, but they have started a particular drug and have noticed it a bit more. Well, is that related to the drug or not? In terms of serious side effects, we have not noted anything yet since these drugs have come to market that have changed how how we use them. But we are aware of side effects, and any side effect has to be taken seriously
Mhm.
and considered in any patient. Because just because it's not a reported side effect doesn't mean that that's not happening in your patient. So you've always got to go back to the patient and try and figure out what's happening with them.
I love it. And that's exactly how you started off today, saying that the patients were going to be the focus of this. So thank
Mhm.
you for bringing that all the way around as well. Thank you for everything that you do and how you are
You're
leading
welcome.
and
You're
showing
welcome.
others. It's always a
And
joy to spend time with you. I look forward to seeing you hopefully in human form soon as well, my friend.
yes, that would be
Yay.
wonderful.